Doc, are you able to tell us, and I'm sure you are, what basically is this policy, the NHIS Capitation policy, about? Once we understand it, I'm sure we can begin to look at the merits and demerits of it. What is the policy about?
Thank you very much indeed. I think I have to, in the first instance, debunk the feeling or the impression that is cash and carry in another form. It's not at all.
Okay.
You know, health insurances all over the world have various methods of paying the healthcare service providers. And there are several others, but three main methods are what we call fee-for-service. We have DRG, diagnosis-related groupings, and then we have capitation. Now, Ghana, when we started the health insurance, everything was fee-for-service. That is, if you treated somebody, if you treated for 10 conditions, you take a fee for 10 conditions.
Okay.
Now the DRG is, you find a group of like conditions which require essentially similar package of resources to treat, and then you put them together so that anybody that comes with a diagnosis within that group, the service provider charges for the fee for that group. Okay. Now, that was introduced in Ghana in 2008.
Okay.
So we started with fee for service, and then we introduced capitation.
Fee for service at what time?
2005.
Okay. And then the DRG came in 2008.
Yes. Let me say that when DRG came, we did not stop the fee for service. But the fee for service was reserved for medicines. In other words, if you give 10 tablets of paracetamol, you multiply the price of, the one tablet by 10.
Okay.
Now, capitation, I must say there are many countries that are, implementing capitation worldwide. We have the UK, we have third world countries like Thailand, like Chile, like Nigeria, several other countries. Now, in capitation, what it means is that you assign, or providers have certain number of subscribers assigned to them or chosen by the subscribers. And then you give a fixed amount or a capitated rate, a fixed amount of money per individual subscriber to the provider to provide a certain set of determined services for a determined period of time. So, the rate has to be determined, the number of people has to be determined, and also the period of time has to be determined. There are countries where they would pay the rate every year. There are countries where they will pay it every 3 months. There are others that will pay it every month. Now that's what we're doing. We are paying every month.
Okay.
Again, let me stress that capitation is not another form of insurance. It's not another, it's not a replacement for insurance. It's just one of the ways of paying our healthcare service providers.
I need to understand that. You say it is not another form of insurance.
No.
And it is not another way.
It's not a replacement for insurance either.
It's not, and it's neither a replacement or another way of it.
No.
So what is it?
It is a payment mechanism. It's a payment, a way of paying our healthcare service providers. So at the moment we have fee for service for medicines across the country.
Okay.
We have DRG for services across the country. And we are doing a pilot of the capitation in Ashanti region. So it's after doing the pilot, learning the lessons that there are to learn, then we will roll it out across the country.
So we need to get that clear right from the beginning. You're saying capitation is not a replacement?
It's not a replacement.
It's just a mode, a way of
paying the providers. And it's not cash and carry.
And it is
nothing cash and carry about it at all.
Okay. That's by way of introduction. We'll leave it at that for now. And I will still stay with the NHIA. Well, sometimes when you have two guests from the same outfit, you have to share the concerns between them. And I don't know how we'll have to deal with that. But Winfred, let me come to you, because you are Director of Strategy and Corporate Affairs, etc. Corporate Affairs, that's it. I have this document before me. There's the NHIA holding a forum on capitation with stakeholders. It's signed by Ni Anan Ajete, who's Communications Manager, Strategy and Corporate Affairs Division, which I believe is part of your division. And there are a number of issues that have been raised in here. Let me begin with the payment or fee, because there's also another issue here about the GMA opposing this whole thing. It says that the General Secretary of the Ghana Medical Association has faulted benchmarks used by the NHIA to pilot the capitation system in Ashanti region. It gives a whole lot of issues. Private doctors here have raised a whole lot of issues. And let me read this to you. As physicians, we need to assure that payment models do not jeopardize the care we provide when we accept higher levels of personal financial risk. That is Dr. Kwadwo Ejako. But they go on to mention some figures, 1.5, 1.7, etc., and all of that. What is it that you gather forms the reason for the objection to this capitation being as a means of payment?
Thank you very much for this question. We are still trying to come to terms specifically to the reasons for the objection, and I'll tell you why. Because we've had various stakeholder engagements on this particular payment system called capitation. I remember during the primordial times of capitation, before capitation became a form, we even made presentations at one of the annual general meetings of the Ghana Medical Association. Following that, we've engaged a number of stakeholders in the Ashanti region. It's been about 20 months of preparation in the run-up to the introduction of capitation. In fact, we have delayed the start of capitation almost 4 to 5 times throughout the period just to accommodate concerns about capitation and the form capitation should take. And in fact, the current GMA president, for instance, was a member of a district implementation committee that was formed in the Ashanti region to actually deal with issues concerning capitation. I should also put on record that even before capitation was introduced on 1st January 2012, there were objections to capitation. Now, at one of the stakeholder engagements and meetings, what we did was to invite stakeholders to say, well, what are the issues here? If the issue happens to be the per capita rate, this is the way we calculated the per capita rate. If you have any alternative, bring them forward. Let's look, and then let's agree on a certain rate. If there are no alternative, the figures that we've put out there are not our own figures. These are industry figures based on your own figures that are compiled on a regional basis. And it's on this basis that we arrived at this per capita rate, whatever it is. Now, there happened to be some confusion over the per capita rate and then the per encounter rate. I mean, from this point onwards, I don't want to use the technical terms. Per capita rate simply meaning that the amount of money we pay for every active member of the National Health Insurance Scheme. Compared to a per encounter rate, which is the amount of money we pay when you actually visit the facility.
What's the difference in practice?
In practice, this is what it means. Now, you pay a per capita rate to cover the whole population of NHIS active members, whether or not they are ill. There are some people who for a whole year will not go to the hospital. And there are some people who will go to hospital maybe 2 or 3 times, depending on the situation. But what capitation requires is that you look at the total number of active members, and then you pay that rate for every active member, whether or not that person is ill. So the rate we are talking about is the rate we are paying per active member of the National Health Insurance Scheme per month, whether or not the person goes to hospital.
That's the per capita rate?
That's the per capita.
What is the rate?
The rate for the private providers is 1.75.
1.7 is private?
Exactly.
And then,
one
CD 75 pesos
for private.
Okay.
And then we have 1.43
okay.
for CHAG institutions, the Christian Health Association of Ghana.
Okay.
And then 1.23 for Ghana Health Service. The reason there is a gradient in even the rates is that some of these facilities, GHS and CHAG, receive some level of support from government, whereas private providers do not.
Okay.
So it was very important for us to put a markup on the rates that the private providers are actually taking.
Okay.
Now, at the end of the period, at the end of the month, the National Health Insurance Authority doesn't go back to providers to say, out of so many number of people I paid for, only 2 or 3 of them came to hospital, so give me the amount covering the rest. It is for you to keep. It's just the basic principle in insurance. How you go and insure your vehicle, every annum you probably pay, let's say, 20 or 40 Ghana cedis. But God forbid, if you happen to involve in a crash and then you go to get some money from the insurance company, you are probably giving way more than that 40 that you paid. How do they get the money? It's because there are other contributors to the vehicle insurance pool who did not get accidents. So they are able to put all those figures together to give to you.
And if you don't go and claim as well, then it's gone for the period, and you have to pay another one the following
You have to pay another one. So in our case, it's for every month, and then it's per member. So that was the understanding we had to get on this. And the second issue had to be about the amount and how it was arrived at.
No, let's deal with the per encounter rate now.
Okay,
because you finished with the per capita rate, and I hope people are following and do get it. So that is the 1.75 for private, 1.43 for public, and GHS 1.23, and that is paid every month.
Every month, in fact, upfront, even before service.
Okay. Now, what happens with the per encounter rate?
With the per encounter rate, that was what my colleague here tried to describe under GDRG, where you have bundled services. I mean, you go and then for every encounter, you fill the claims form, submit to the National Health Insurance at the end of the period, and then it comes to our claims processing centers, we process, and then we pay you back. And if you would recall, some years ago, you would hear public outcry from our service providers saying, look, NHIS owes us for 7 months, for 6 months, they are not paying. This happens to be one of the weaknesses that capitation intends to correct. Okay, so that is the per encounter rate, where you fill claims form for these diagnosis-related diseases.
Do we also have fixed figures in relation to per encounter rates?
For the per encounter rate, it ranges from somewhere around 6 to 12 Ghana cedis, depending on the level of the facility.
And does it matter that it's private or GHS or public?
Yes, it really matters. So it's a range.
It's a range between 6 to 12 Ghana cedis.
It's a range between 6 to 12 Ghana cedis.
So the treatment falls outside of this. What does it mean? I mean, if it's more, perhaps is what I should be saying, not just outside. But if it costs you 17 cedis for the treatment or whatever, what happens to the balance of, say, 5 Ghana cedis?
If it costs more than, the treatment is more than that. You know, we have what we call NHIS tariffs, which happens to relate the conditions to the amount of money that we pay to service providers. And I'm talking about per encounter. And this is an exercise that is conducted periodically and adjusted based on inflation to reflect reality. So it's a very scientific process to determine that rate. So the rates that we agree upon and the rates that we actually publish as our tariffs are all those rates that the experts, based on industry survey, have agreed to say, if I'm treating you for malaria, it shouldn't cost you so much. So that's what I have to say. So there's nothing like it's going to go way above it. I mean, when it's going way above it, there's supposed to be a review. And as we speak right now, there's currently a tariff review going on for the National Health Insurance Authority. And but
it may not be way above it. I'm just asking for the people out there, because this is a program for viewers. And someone at home is saying, okay, 6 to 12 is your rate. I go and it costs 14 or 15. What happens to it, to the extra?
No, you see, for you, the NHIS subscriber, you really do not have to think about this thing is going above what. Because between us and the providers, if it is malaria, we have a tariff, and we've given that to you as a service provider, that this is how much we are paying for malaria. So as a subscriber, you just go, you have malaria, the doctor treats you, and all you need to ask is malaria covered under National Health Insurance Scheme. If it is yes, you are supposed to get your treatment and go back home.
Irrespective of how much it costs.
Yes, the rest is between the service provider and the National Health Insurance Authority through the tariff regime. So the tariff regime is what actually spells out what we have to pay for a particular condition.
Really trying to understand what it seeks to do, and the scrutiny it seems to be coming under. Before I go to you, Prof, because I'll engage you quite a bit, let's get the reaction that Doc was trying to bring in, or say a further clarification of the point I get from your colleague.
Thank you very much indeed. I just wanted to place on record that these rates, whether they are DRG,
yes,
or there are capitated rates, they are not determined by, NHIS sitting alone. We always involve the provider groups, and indeed there is a committee, a capitation committee, which comprises NHIS, Ghana Health Service, CHAG, private medical practitioners, pharmacists, So I just wanted to make that clear.
Okay.
But these rates are determined by, and indeed we had an international World Bank consultant as well.
Okay. Yeah. Dr. Kwame Antwi is president of the Society of Private Medical and Dental Practitioners. He's on the telephone line right now. Good evening to you, Dr. Kwame Antwi.
Good evening.
Thank you for joining us. We are discussing the NHIS capitation policy. What do you make of it?
What aspect of it do you want to know, please?
Do you basically, is it a good policy?
We have stated time and again that basically we find that it's good. It's good in that the capitation, what we are doing at the moment, before the capitation, we were paid in arrears. Capitation promises to pay us in advance. And we found that will be very good. And it also have the patients not shopping around. That is just a set of clients who have been allocated to you, and that they'll be hopping from one facility to the other in search of medical facility. That they'll be stuck with you. They only go to a referral center when their need arises, and you refer to them. So we said in that aspect, we welcome it. It's good.
In what aspects don't you welcome it?
What aspect we don't agree with is the rate at which they are going to pay us, and then the number of the way they went about enrolling the clients to the facilities. Do you know there are some facilities where they have been enrolled only about 5 patients or 10 patients or even 100 patients? When we are giving this number, whatever rate they are going to pay you is going to collapse your business. Which means if you are giving, say, 5 patients and they pay 1.75, multiply that, and then you see that the rate the money you are going to get will be less than 8 cedis for the whole month. I don't know which kind of facility is going to be able to accept this and then work and sustain itself. So we found out the whole thing is being bungled, and we are going to lose drastically and then collapse the health facilities as we know them to be. That is why we are against it.
What's your recommendation?
The recommendation is that we suspend the capitation as it is being enrolled now, and then we sit down with the National Health Insurance Authority and all the agents involved and work out an agreeable settlement. That is the way forward.
Do you have any rates in mind which would be better, more workable?
We have a rate which we have communicated with them, but we are saying that this rate isn't cast in iron and stone. It's still subject to negotiations. That is, we sit down and then debate whether it is acceptable to them and also to us, and whether it's going to be fair or it's not too fair. We have communicated this to them. And if you may care to know, the rate is around 20 Ghana cedis per patient.
20 Ghana cedis per patient is what you are recommending. Thank you very much. I believe that your point is made. It's clear to us. But before you go off the line, I believe that the NHIS officials, you want to address him?
No, just quickly. Just to make a point.
No,
here.
I mean to him or not?
Yes, okay. Just to. He made mention of 20.
No, if you want to discuss it, we'll let him go.
Okay.
That's what I'm asking you, whether it's to him.
That's fine, we can let him go.
So thank you very much, Dr. Kwame Antwi, for joining us. Enjoy the rest of your evening. All right. So yes, you can state your case now.
Yes, he made mention of 20 Ghana cedis per patient.
Yes.
You understand? That is where there seems to be a challenge. whilst we are talking about per active member of the National Health Insurance Scheme, whether or not the person is ill, they are still looking at per patient. Patient meaning the person is ill. So they are proposing a rate of 20 Ghana cedis, which you would probably want to compare to the 12 Ghana cedis we stated earlier.
6 to 12.
6 to 12 Ghana cedis we stated earlier.
Okay. And the 12 will be them because it's private.
Exactly.
Okay.
Exactly. So you understand what I'm saying. So this is where we need to draw the line. Okay. That under capitation, we are paying for every active member of the National Health Insurance Scheme, not sick people who are coming to the health, not patients. Right. So they need to re-look into
But we need to understand this.
Right.
From, and I need to understand this a little bit more. Okay. Because when you say per patient in the scheme, how does that affect the private practitioner? Because I think that the private practitioner is able to gauge his activity or her activity based on the people who visit, the patients.
Exactly.
And that is why they are talking about a figure per patient.
Sure.
But when you, from your end, say that everybody under the scheme, it may not affect them. And that's why he told you it's possible for him to even have 5 patients or less. And for that matter, they don't find it sustainable.
That's great. He made a good point today.
Yeah.
During the preparation stages of capitation, we did realize that subscribers had a choice to make. So just go out there as a subscriber and choose your preferred primary provider, the person you want to be visiting when you are ill. These were choices made by the subscribers, not choices made for the subscribers by the NHIS.
I'm afraid I have to go back onto the phone line quickly.
Please.
And strangely, I have a guest who hasn't spoken for half the time of the program. It has never happened. But Dr. Frank Sribo is General Secretary of the Ghana Medical Association. Good evening to you, Doc.
Good evening.
Thank you for joining us. We are talking about the NHIS capitation policy. And if the news reports I have before me are correct, the Ghana Medical Association seems to be opposed to the NHIS capitation as it stands right now. A few of the headlines I have says a GMA calls for suspension of NHIS capitation project in Ashanti. And also there's another one that says GMA General Secretary punches NHIS capitation. Do those represent the position of the GMA?
Well, I think that GMA's position has not been something that we have hidden. We have indicated that in principle we are not against capitation. It is the manner in which it is being implemented that we feel it is not right, and that there is the need for further consultation, and that there is a need for suspension to happen now so that the consultations can go on. And when all stakeholders are happy that what is going to happen is right, then it can go on. So that has always been the position of GMA. And we have indicated that in principle we are not against capitation, but it is the manner in which it is being implemented that we feel that it is not right.
Why are you calling for an immediate suspension?
Well, I mean, like any other pilot study or like any other experiment or study that you undertake, if you realize that the adverse reactions are so much and the adverse effects are of dire consequences, there is always the need for you to suspend it and then look at it again and then come back. There is no need to continue when you are just heading towards a blind alley and you don't know exactly where you are going. And that is exactly what is happening. And we have indicated that the way it is going, that is the reason why the private practitioners have decided they are not going to be part of it. Because most facilities are going to collapse. And before Health Insurance Authority realized that they have collapsed the facilities cannot be resuscitated. And that is a very huge problem. Remember, in Ashanti region, the private practitioners even form about 50% of the providers as far as health is concerned. And even the public sector is even suffering. But the issue is that if you come to the public sector, salaries are paid by governments, and obviously are government facilities. So when they collapse, they virtually collapse on government. And government would always be able to pump in funds to resuscitate these hospitals. But what about the private practitioners? So really, we feel that, and even the members or the people themselves, the clients who assess health in the region, most facilities are recording low turnout because of the low or the ineffective education that went on before the implementation of capitation. So there are a lot of problems that are solved with this capitation process that we feel that there is a need for suspension, and then we'll look at all the problems that are coming on board so that we can deal with the problems before National Health Insurance Authority goes on with it. Remember, initially, even ANC services were in the basket. That means that there was not enough consultation. Otherwise, how would you put ANC even in the capitation basket? When you do that, what happens is that people will tend to deliver outside homes and so forth, because what is happening is that the money for the capitation is so low that no facility will be able to actually even deliver a single woman based on what has been given. They have taken that one out of the capitation basket, but that was after about a month of the implementation processes. So what happens to those who have already delivered people under the capitation process, have done episiotomies and so forth, that they have spent so much on? So there are a lot of problems with it, and we feel that there is a need for that suspension to happen now so that further consultations can go on.
If I gather, if I get you and understand you, the problem you've really highlighted by name is the lack of sensitization and education prior to the rollout of the policy. And
that aside,
okay.
That aside,
yes.
That aside, the capitation rate, the per capita rate is so low, very, very low indeed. If you take a per capita rate of 1 cedi 75 pesos for each patient, and even for facilities like private, let's say the private facilities, you say that you even assign 1,000 patients to those facilities. That means that the person is going to take 1,700 Ghana cedi. And for you to qualify even to do NHIS, for NHIS accreditation, you need to minimum have a doctor, have a nurse, have a cleaner, have a dispensing technician, and obviously have some 1 or 2 additional support staff. Even the 1,700 alone cannot pay the doctor. How much more the other people? How much more about the bills that goes on in terms of utilities, electricity, water, and so forth? What happens to all of them? And people say that the capitation is just part of the things that you are supposed to do as far as NHIS is concerned. But most of the facilities do only OPD. Most of the facilities do only OPD. And if for nothing at all, somebody who has not done any statistics at all understand that previously under the previous DRGA, what you can do was claiming at least, let's say, 80 million, that's 8,000 Ghana cedi, and now he's getting about 800 Ghana cedi. And the difference, nobody can tell me that the difference is not huge. Indeed, the CHAG institutions have done some kind of small statistics themselves, and they are indicating that when they did it, the average per capita rate for each patient per day is actually 22 Ghana cedi, not per month, per day, 22 Ghana cedi. And if you are giving 1 cedi 75 Ghana cedi per month per patient, that is woefully inadequate. So obviously, we know that yes, National Health Insurance Authority actually is trying to do what they call cost containment, but you cannot do cost containment at the detriment of the people who are actually providing the service and the people who are going to receive the service, and that cannot be done.
Dr. Frank,
so cost containment, health is always expensive. Nobody should think that health is cheap, and we can't say because of that. Remember, they are talking about the system going to collapse and so forth. Indeed, the system will not collapse because we know, even as workers, we contribute part of our SNIT to the National Health Insurance Kitty. And everything that you buy on the market, you contribute at least 2.5% of the VAT rate to the National Health Insurance Kitty. It doesn't mean that we should misuse the money. Yes, we know that the money should be managed prudently, but then you don't put the people's lives at risk at the expense of cost containment. That is not right. That cannot be done. And
all right.
You use a large percentage of your subscriber base, which is 25% of your subscriber base, as a pilot project.
Okay.
That also doesn't gel. So really, we feel that it is important that the National Health Insurance Authority go back and then sit down, look at all these issues again before they come out.
Well, Dr. Sribo, thank you very much. We have to NHIS capitation policy is what we are discussing. Doc, I need you to do this very quickly.
Okay. Thank you very much indeed. First, I think Doctor talked about no consultation, but I must say that there has been a lot of consultation, and we are still in consultation. Indeed, Friday we have a meeting with the society in Kumasi, and talking about removing antenatal. These were all parts, a result of the consultation. We've been having forums, and with the suggestions that come up, we respond appropriately. So antenatal, postnatal, and deliveries are out of the capitation budget. Now, talking about talking about the child having done work and 22 Ghana cedis, that was a combination of outpatient and inpatient. And now hitting about the rate, the scheme, the capitation will not collapse facilities. in the sense that, yes, they may be doing only outpatient. But outpatient, it's not only the capitated basket of services that they do. There are other things that they do. You know, they may make some diagnoses that are outside the package. They may also do some laboratory tests that are outside the package. They may also give some medicines that are outside the package. Whatever is outside the package is paid by DRG. So the capitated amount is not the only monies the facilities are getting. They are getting monies related to DRG claims as well.